Welcome to the Practicing Clinicians Exchange podcast. This podcast series was developed from a live PCE conference focused on gastrointestinal and genitourinary cancers, including gastric cancer, colorectal cancer, hepatocellular carcinoma, bladder cancer, and prostate cancer. In each episode, you will hear the latest evidence and expert recommendations for the care of patients with the specified malignancy. In this podcast series, each of these topics will be discussed in 2 podcast episodes covering didactic presentation of the available evidence, relevant case discussions to illustrate clinical implementation strategies, and the audience Q&A session. Be sure to listen to the 2 podcast episodes for each topic in sequential order, as they may include examination of continuing case studies with patients progressing through different stages of their care. To claim your credit, please visit pce.is/GIGU.
Welcome back to the GIGU Oncology Boot Camps powered by PCE. My name is Terran Sims, and I'm a nurse practitioner in the Department of Urology at the University of Virginia in Charlottesville, and my focus is urologic cancer. Today, we're going to talk about a new array of choices in prostate cancer. What's best for your patients? We have 2 faculty for the 2 presentations. We will start today with Dr. Rana McKay, and Dr. Balar will join us for the case study. Dr. McKay is our associate professor for the Department of Medicine, Division of Hematology, Oncology, and Urology at the University of California, San Diego in San Diego, California. And I want to remind you of our learning objectives for this session. We want you to summarize available and emerging agents across the continuum of prostate cancer, apply efficacy and safety evidence, molecular testing, and guideline recommendations to develop treatment plans for patients with prostate cancer, and implement strategies to identify and manage AEs associated with treatment of prostate cancer.
So now shifting gears to talk about chemotherapy for metastatic castration-resistant prostate cancer. We've had a long run with chemotherapy with 5-FU, cyclophosphamide, mitoxantrone. All of those agents were never demonstrated to improve overall survival for patients. It is when docetaxel enters into the clinic in 2004 that we have the first agent that's actually able to demonstrate an improvement in overall survival. And then cabazitaxel, which is a second generation taxane in 2010, entered into the clinic and demonstrated improvements in overall survival in patients who were docetaxel pretreated. We do see cytopenias with this agent. I think that's something to be mindful of. Generally with cabazitaxel, growth factor support is recommended, and it is approved for use at the lower dosage of 20 milligrams per meter squared. So I want to highlight the results of the CARD trial, and this is a pretty relevant modern day trial that was conducted. There's been a lot of agents that have entered into the clinic, but not a lot of studies that have looked at, well, what's the appropriate sequence of agents? What's the best strategy to sequence therapies? And the CARD trial enrolled patients who had metastatic castration-resistant prostate cancer, who had seen prior docetaxel, and they had received prior abiraterone or enzalutamide. And patients were eligible for this trial if they had progressed on either abiraterone or enzalutamide within 12 months of initiating therapy, which honestly is the majority of patients who, the bulk of patients who get abiraterone and enzalutamide in the CRPC setting progress within a 12-month period. There was a statistically significant improvement in rPFS with the use of cabazitaxel of 8.0 months compared to 3.7 months, the hazard ratio for progression or death of 0.54. And there was a statistically significant improvement in overall survival when patients switched mechanisms. Instead of going to the alternate agent of Abi or Enza, going to chemotherapy with cabazitaxel resulted in a statistically significant improvement in overall survival. Cabazitaxel OS was 13.6 months compared to 11.0 months with a hazard ratio for death of 0.64. And so I really think that this trial helped affirm that, yes, switching mechanisms after progression on an AR targeting agent is probably the right strategy as opposed to just going to the next agent. Similarly, when we look at the PROfound trial was looking at comparing the efficacy of olaparib compared to abiraterone or enzalutamide. Patients were eligible for this study if they had progressed on abiraterone or enzalutamide and had an alteration in one of 15 pre-specified homologous recombination repair genes. There is a statistically significant improvement in rPFS for patients that were enrolled on the trial, looking at the intent to treat population. This is all comers on the trial. And also there was an improvement in overall survival. This OS was not statistically significant for the intent to treat population. The OS that was statistically significant was that for the patients that had BRCA1, 2, and ATM alterations. The data for Triton 2 demonstrating similar efficacy of rucaparib. So a lot of things to consider, not too different from what we were considering for metastatic hormone-sensitive disease. So there are patient factors of preferences, comorbidities, what's been their response to prior therapy, symptoms, performance status. There's disease factors. Where are the metastases, bone, visceral, high volume, low volume, and then genetic factors to consider. And then there's also treatment factors. What's the toxicity profile of the agent? What are drug-drug interactions? Does that agent mitigate pain? What are the effects on quality of life? What's the experience of use with that agent? So these are all things that we look at in the clinic. I think shared decision-making is critically important to come to the right treatment strategy for any given patient. Patients and clinicians collaborating together on selecting a treatment. This is really important, especially for oral agents and adherence to those agents, ultimately resulting in better treatment responses for patients. And then just a little bit on managing AEs to maximize adherence. I think despite improvements in quality of life with many of the androgen-directed therapies, they are not without adverse events. So patient adherence to therapy due to AEs can sometimes be challenging. We've talked about some of the side effects of specific to abiraterone and enzalutamide and the AR targeting agents. I think it's also important to talk about side effects to just ADT in general, from fatigue, hot flashes, cardiovascular risk, bone health, psychologic effect, diabetes. So I think it's really important to be talking to your patients about this and really optimizing care. I think this is actually probably the bulk of what we look at in the context of people who have metastatic disease. And then partnering with primary care is key. It's a key strategy to adherence to therapy. Again, making sure patients' blood pressure stays in check, making sure their diabetes stays in check, and their chronic conditions are being attended to. I think this is really just a key cornerstone of survivorship. Again, these are sort of additional AEs and strategies that can be used to mitigate those AEs for hot flashes, different agents that can be used, bone health, calcium, vitamin D, getting DEXA scans, use of osteoclast targeted agents. For cardiovascular disease, it's really doing a risk assessment, I think, initially, and really partnering with primary care to make sure that patients are optimally cared for. Of course, we can't bring up prostate cancer without talking about sort of the pandemic that we live in COVID. So cancer and some of its treatments can compromise patients' immune systems and put them at higher risk for infection than the general population. I think decisions for diagnosis and treatment of prostate cancer should be made considering safety, but should not be delayed due to COVID. Biopsy should not be delayed when there is concern for potentially lethal prostate cancer. COVID-19 vaccinations are not contraindicated. It's actually recommended that our patients with cancer get vaccinated because they are certainly at higher risk of complications. And now our boot camp takeaways. So we'll go through. So for patients who have metastatic castration-sensitive prostate cancer, it's now standard of care to intensify therapy with docetaxel, abiraterone, apalutamide, or enzalutamide in addition to ADT unless there's a strong contraindication. It's important to discuss the potential adverse events that are associated with the individual therapies with your patients before selecting a treatment regimen and considering early use of approved agents, apalutamide, darolutamide, enzalutamide for non-metastatic CRPC to improve metastasis-free survival, overall free survival, and quality of life. It is recommended that germline testing and counseling be performed for patients with metastatic, regional, or high-risk localized prostate cancer. And we certainly recommend somatic tumor profiling in all patients with metastatic prostate cancer.
We're going to move right on because we want to get to the case study panel discussion where Dr. Balar will also join us. So here's our first case. We have at least time for one case, I know. He's a 72-year-old white male with a history of hypertension and dyslipidemia. He has a history of prostate cancer, high risk, Gleason 9, PSA 13.3, clinical T2, treated with external beam and ADT for 2 years, and developed rapidly rising PSA 3 years after completion of ADT with a normalized testosterone. His PSA 7.3 and a PSA doubling rate of just 3 months. Imaging confirmed evidence of metastatic disease in extrapelvic lymph nodes and pelvic bone metastasis. Dr. McKay and Dr. Balar, who can start us off with some discussion of this case?
This is not an uncommon scenario that we see in the clinic, patients having localized disease, high-risk localized disease. I think these are the patients that ultimately end up developing metastatic disease for those subset of patients with localized disease that are destined to do so. When I think about patients like this, what gives me a little bit of pause is sort of how long did it take for their PSA to rise? Did they have from time to diagnosis to time of metastases? This patient is developing metastatic disease within a 5-year period of being diagnosed with localized disease. And then looking at where their sites of metastases, what the PSA doubling time can also be insightful. This patient's got pelvic bone disease. He's got extraprostatic, lymphadenopathy. There are no visceral metastases that are detected. The PSA is still pretty low, but the doubling time is rapid. So, categorizing this patient as metastatic hormone-sensitive disease. And, it's hard to glean from this case exactly if he kind of falls into that bucket of high volume or low volume. He certainly doesn't meet that de novo criteria because he didn't have, he had a history of localized disease. So I'll sort of start there and then maybe we can talk about treatments in a minute.
Yeah, I completely echo with what Dr. McKay said. The patient has hormone-sensitive disease by virtue of, a recovered testosterone, but having Gleason 9, PSA 13.3, and such early recurrence just a few years after completion of primary therapy, I would suspect a low PSA relative to volume of disease. And I'm just going to guess that with bone mets and pelvic nodal disease, a PSA of 7.3 can't be good, and a doubling time of 3 months. So, while this is hormone sensitive up front, I don't think either of us would expect that this patient is going to do well with just ADT and a novel hormonal agent alone. And this is someone that we might even consider, treatment with chemotherapy front as well as per the triplet, data from PEACE-1 and others. But obviously a patient like this, unfortunately, prognosis for these patients, unfortunately, is not so great.
Yeah, I would agree with that. I think, favoring ADT plus, I tend to favor docetaxel. So this patient doesn't necessarily exactly fit the PEACE bucket because he didn't have de novo disease for triplet therapy, but I think definitely needs doublet. And I think chemotherapy is a great option. I think we always want to look at scans, so I think getting a sense of what the patient's scans look like is going to be really helpful and insightful to decide, is he low volume, is he high volume?
Yeah, thank you both. I do think these are the kind of patients that are so surprised that all of a sudden when they thought they were sort of cruising along after surgery and then a rising PSA, all of a sudden they're in real trouble and we consider them to be unbelievably high risk for progression. And they need a lot of shared decision making and also just a lot of support from their team because they're probably going to be looking at chemotherapy. I would agree. And that's a surprise to them when they think about all the oral agents they were hearing about before that now, in fact, they're probably best suited for something like chemotherapy. It's a tough group of patients. All right, let's look at our second case. I think we have time. So here's case 2. A 64-year-old African-American male with a history of diabetes and hypertension, diagnosed about a year ago with advanced prostate cancer with bone mets, currently undergoing treatment with abiraterone. He was initially treated with Zoladex for 6 months, which had no results. His current treatment's been ongoing for 5 months, and the PSA has been fluctuating between 20 and 100. He's experiencing excruciating pain in the lower extremity, blood in his urine, weight loss due to little or no appetite, hot flushes, which appear to be a side effect of his abiraterone. What would you do with this patient? Dr. McKay?
Sure. I'll dive right in. So I think step back and think like, who is this patient? The underlying diabetes, the underlying high blood pressure, that's probably exacerbated by the abiraterone. I think it's critically important to be ensuring that we are doing everything we can to optimize his other comorbidities, make sure he's able to actually stay on the abiraterone, that the abiraterone isn't exacerbating those agents. But I think what's most impressive now is that it does seem like he's actually having some disease progression. When my patients are having excruciating pain, I worry about that tremendously. I image frequently. It's not uncommon that I see patients refer to me where they've gone years with no imaging and treatment decisions being made based off PSA alone. And so I think it's critically important to obtain imaging, obtain scans. These patients can be at risk of pathologic fractures related to their disease. They can also be at risk of fractures just related to the fact that they're on ADT, insufficiency fractures, So the first thing that I would do is image to see where I'm at. And if the patient is actually having radiographic progression, I would consider radiation therapy versus, depending, this lower extremity makes me worried, like, sometimes if patients have a lesion in their femur, like that's a weight-bearing bone, and sometimes patients may need pinning. So I think the first, even just doing a crude X-ray may be helpful. So kind of get an X-ray, get imaging, see what's going on with the leg, see if there needs to be some sort of metastasis-directed therapy there, whether it be surgery or radiation. And if the patient is having radiographic regression, when it sounds like he's having clinical progression just from the weight loss and the pain, probably shifting gears. And generally, when I think patients having pain, in my mind, I'm thinking they probably need chemo. And especially this person who's kind of progressing on Abby.
I would echo the same comments. A few pieces about this patient's history that are a little bit curious to me that ultimately imaging is going to sort out, which I completely agree with Dr. McKay that, for patients with hormone sensitive disease that quote unquote cruising on, let's say, doublet ADT abiraterone or another novel hormonal agent, I still do imaging at least, once yearly. The moment patients enter castration-resistant disease, even if they're doing well, it's probably still every 6 months that I'm going to do it. Even on studies, they ask for it much more often than that, although we often can't get approved imaging that often, especially without PSA progression or clinical progression. But that being said, though, patients can have disease that's progressing underlying, otherwise normally behaving PSA. So you just can't really put your hat on that too much. What's interesting about this case is that the PSA is fluctuating between 20 and 100, so I'm not sure what to make of that. Hematuria in a patient like this either makes me worry about locally advanced disease. So, was the prostate in situ and you have a locally advanced tumor? Or is this a patient who had prior pelvic radiotherapy? And is this, simply radiation cystitis? And this is simply, a toxicity related to prior therapy, but not, disease progression. Obviously, the presence of excruciating pain and, either lower extremity, I 100% agree with Dr. McKay that this is big red flag for disease progression. And this absolutely has to be sorted out. And sometimes surgical intervention with a pen is sometimes necessary for a weight-bearing, site. One thing is clear that, for patients with diabetes and high blood pressure, probably abiraterone may not be the best choice. The concurrent prednisone can be a big challenge with some of our patients here. And so perhaps enzalutamide or, an AR antagonist is maybe perhaps a better choice. And sometimes I've had actually luck in actually getting darolutamide for some of these patients, even before, when it was only approved, as it still is, only for non-metastatic disease. So I've actually been able to get it for some patients, especially when they have medical contraindications to abiraterone and prednisone.
It's a great point. I do wonder about the choice of abiraterone with his diabetes, because that's a challenge, even if he does well on it, it's a challenge to manage right off the bat. So you wonder if he might have been better suited to something else. Any other thoughts about this case?
Yeah, no, this is great. I think also, the hot flashes can be incredibly problematic for patients. I think there's a lot that we could do. This is just part of survivorship care, from Fexer to Megaze, gabapentin. There are also lifestyle changes that can be made, like something as simple as putting a fan by the bed, linen clothing. Like, these are all things that little pearls that we have to help patients mitigate their side effects and really try to maintain their quality of life. So I think it's kind of that big picture, holistic, care. And for somebody like this, that sounds like he was on Zoladex, then progressed, and then sounds like he was received abiraterone. So maybe was getting abiraterone for castration-resistant disease. It's in this context where patients are recommended for osteoclast targeted therapy. So the role of osteoclast targeted therapy for metastatic hormone sensitive disease is really not for SSE prevention. There's been a large cooperative group trial that looked at zoledronic acid in this context, and it basically was negative. And so really the role of osteoclast targeted therapies for the metastatic hormone sensitive setting is for treatment related osteoporosis and osteopenia. But when somebody enters into castration resistant disease, that's when you really want to make sure that you have, routine use of bisphosphonates or denosumab to prevent symptomatic skeletal related events.
Great points. Thank you. I think that's great. I think we'll move on to the Q&A from the audience, because we have a lot of questions today, if that's okay with everyone.
Of course.
So we'll move to the Q&A, and I'll go through the questions from the audience. Here's a question. What would you recommend as the next step of treatment for a patient with metastatic castrate-resistant prostate cancer and severe bone pain? Sounds like our last guy. Currently receiving abiraterone with prednisone without improvement. So it sounds like our last case, but you might have some other thoughts about this question.
Yeah, I don't mind diving in here. So I think if this patient has bone-only metastases or low volume lymph node metastases with bone metastases, like lymph nodes less than 2 to 3 centimeters, radium-223 may be a great option. Radium-223, as I stated, is a liquid radiopharmaceutical. It is particularly helpful in mitigating bone pain and mitigating symptomatic skeletal related events. It's given IV once a month. Patients tolerate it really well. It's not chemotherapy. So that could certainly be something that could be utilized, especially given the severe bone pain. When I think about severe bone pain, I think, again, it's important is it generalized or is it focal, and do they need radiation to that area? Because a lot of times our systemic therapy, we can have a better local effect with radiation than with systemic therapy per se.
Agreed. Dr. Balar, would you like to add anything?
Not much to add. I 100% agree with radium. Diffuse bone pain, you can probably lean on that. If it's focal and limited, I think SBRT can sometimes be very useful in patients like this.
Would you have to discontinue the abiraterone if the patient received radium-223?
Probably should, because a randomized study suggested, pretty bad skeletal related events. And although that seems to be mitigated with the addition of, bone protecting agents. So, kind of balances itself out. But the question really is on balance, if a patient is on abiraterone and having clinical progression with worsening bone pain, that to me is treatment failure. So it begs the question, should you continue abiraterone in that case anyway?
Thank you. All right, here's another question from the audience. How often do you order advanced imaging? I think they're probably talking about PET or F18 or F18 PSMA with radiographic progression. What's your go-to test? Dr. McKay?
Sure. I mean, I think it all depends on context. In the context of somebody who is high risk localized, and I'm worried that they could have metastatic disease that I'm missing, I do order next gen imaging in addition to my standard imaging. I want to look at kind of concordance between the two, because quite honestly, you're probably not going to be able to follow somebody with like serial PSMA scans every couple of months. Like it's just, not going to be feasible. So I like to not get the PSMA scan in a silo where I don't have standard of care imaging to compare to. So I think if they're high risk localized, where I'm worried that they could have metastatic disease, I get it. I think in the biochemically recurrent space, that's where it's particularly useful, rising PSA, and you're kind of trying to find bone metastases. Also in the non-metastatic CRPC space, I think it's particularly useful. Where I use it for metastatic CRPC is there are now a series of PSMA-directed therapies that are being tested. Lutetium PSMA is, under review by the FDA. I think it's going to be interesting to see what the FDA says about mandating PSMA scan prior to use of that agent. I'm not sure what is going to ultimately be a part of the label, but I think sometimes in the metastatic CRPC setting, it is utilized. I think we've learned a lot from the Australian group, German group about PSMA-based disease and FDG-based disease. And as people evolve through the NMCRPC spectrum in late-stage metastatic CRPC, we're seeing more of a lineage plasticity and evolution into a neuroendocrine phenotype. And so some of those cancers may not necessarily be PSMA avid. So I think knowing that is important because you strategize around a more of a chemo-based regimen, carboplatin-based regimen in that context. So I think it depends. And those are the scenarios that I use next-gen imaging.
Dr. Balar, your thoughts about that?
Yeah, I think the imaging field in prostate cancer is highly complicated. I think as Dr. McKay has basically pointed out, for clinicians, I think to try our best to simplify it, where I might use next-gen imaging, and PSMA is one of those things that really is useful in castration-resistant disease because you don't really see PSMA expression in castration-sensitive. So really the useful part in patients where they're having a rising PSA, but their testosterone is normal and they're ADT naive, it's, to try to detect, oligometastatic disease and treat what you can with, let's say, RT or some, metastasis directed therapy. So you can kind of kick the can down the road and hopefully avoid and delay the need for ADT. And sometimes, more sensitive imaging, such as, let's say, an Axemin PET might help you. I'll point out, you mentioned F18 PET, right? So that's sodium fluoride. Unfortunately, Medicare no longer covers it and has been that case for the last several years, which has been really tough because we found it very useful. I certainly did back when it was widely available. And so I think that's been tough. But I think as Axemin and we learn more about PSMA, there is, just as Dr. McKay, pointed out, there is a spectrum of this disease as it evolves over time, basically through selective pressure from treatment that we administer to it. The disease evolves and therefore the ligands it expresses and therefore the imaging modalities that we would use to detect it will also change. But early in disease, that's where I find is helping us to decide, can we do metastasis-directed therapy or can we not? And that's where some of the more advanced imaging might be useful.
We have another question from the audience. How would you decide, or what would you recommend to your patient as the course of ADT if they're undergoing radiation for recurrent prostate cancer with nodal disease? I assume that means post-prostatectomy.
That's a very good question. I think what people are getting at there is somebody who underwent a prostatectomy, they either have node-positive disease at the time of prostatectomy, or their PSA is rising and then have node-positive disease after RP. And I think that the data are really challenging in that context around the ADT. I think because first in the salvage setting, we're really thinking about, are we doing 6 months? Are we doing the Chipley regimen of 2 years of high dose bicalutamide alone? But really, or are we going to kind of like extrapolate from the 3% of patients that were on Stampede that were in this scenario where they got 2 years of ADT plus abiraterone? Are you going to therapy escalate? So I think there's a wide variety of practice patterns. There are several clinical trials that are currently ongoing through NRG and through other mechanisms looking at trying to optimize what is the best course of therapy in this context. I think in my practice, I think 6 months of ADT or 9 months of ADT alone for somebody with node positive disease is probably undertreating. I tend to favor escalating with a hormonal agent and favor longer course therapy.
I completely acknowledge what Dr. McKay said about the data here, which either is post-hoc subgroup analysis of prospective data or selected retrospective series. My view is that after definitive local therapy, either with radical prostatectomy or ADT plus radiation, in a patient who then has biochemically recurrent prostate cancer or, the evidence of nodes on a scan with biochemical recurrence, and I guess that's the latter scenario that we're talking about. If you know what nodes you're dealing with, and ideally, let's say it's 1 or 2 nodes in the pelvis, the feeling here is that, ADT is going to likely be part of this patient's care, whether it's now or later. And giving the patient ADT at that point concurrent with radiation is going to eliminate that PSA very, very quickly. And so the purpose of radiation, in my view, is metastasis-directed therapy. That's how I look at it. And it's SBRT, let's say it's to 1 or 2 nodes. And if you can get a PSA response and perhaps save that ADT for later and not avoid some of the toxicity associated with it. So I tend to do that. Now, if it's in the true salvage setting, so you have biochemical recurrence and you're doing salvage radiation to the prostatectomy bed, I think that's a slightly different scenario, but you're treating the prostatectomy bed. There, I think the scenario that Dr. McKay described could be quite reasonable. I think 6 to 9 months, perhaps maybe under treatment, although I know many of my colleagues do around 6 to 9 months of ADT.
Thank you. That's very relevant points for the audience. We have time for one more question. After today's talk, what do you consider the most important adverse event to watch for in patients receiving an androgen receptor antagonist? Dr. McKay?
Honestly, the most common thing that they experience is fatigue. And the longer they're on it, the worse that it gets. And for me, if I need to make a dose reduction or dose modification to keep them on therapy and maintain their quality of life, I don't think that that's an unreasonable thing. I think the other thing is particularly important with Enza, and I see it kind of, not to say missed all the time, but there are so many drug-drug interactions with enzalutamide. It's critically important to do, a thorough screen of the patient's medications. From DOACs, for example, can cause drug-drug interactions with Enza, other agents. So I think that can sometimes come into mind when their patient is seeing a lot of other doctors, and then somebody may prescribe something, then they come to you and you're like, why do you okay, we got to switch you. I got to put you on darolutamide instead of enzalutamide because you need to be on this agent that somebody else started. And, so I think it's really, these things kind of come up a lot in the clinic, but I think with the AR targeting agents, it's the fatigue is, I think, what patients struggle with the most. I know there's a lot of hype around the seizures, but quite honestly, that's a pretty rare event.
Yeah.
Dr. Balar, what about you?
Yeah, 100% agree. Fatigue. The only thing I might add is just that with Enza, kind of the brain fog, and that just happens with patients that are chronically on it. The mental cognition, the sharpness is not there. And this is in addition to the fall risk, so there's fall risk. And then there's this other added layer that happens that patients can kind of report about, but it's just vague and it's very difficult to codify. And I think that's why it's difficult to tabulate and collect on clinical trials. But for a lot of my patients who have been on Enza, they've really reported that. And it has to do with, penetration across the blood-brain barrier. Theoretically, we see less of that with darolutamide. because it really doesn't. But, I'll be honest with you, I've had a little bit of that. My patients report some of that, but probably a little less so with daralutamide.
Thank you. We're going to wrap it up now. This has been a great session on prostate cancer. I want to thank both of our speakers, Dr. McKay for your great talk, and Dr. Balar for adding your thoughts in here in these case presentations, and for our questions from the audience, which have been very helpful in bringing out some salient points.
Thank you for listening to the Practicing Clinicians Exchange podcast. To claim your credit, please visit pce.is/GIGU. And while you're there, don't forget to check out our website for more complimentary oncology CE/CME activities.